الرحيم. السلام عليكم وطاب مساءكم حيث أنتم دوس في المهجر والشتات ودوس في جمر الوطن. تحية لكم جميعا. نواصل النطفو على سطح الصعوبات. هكذا تتقدم الأمم بالصبر والمثابرة. I'm pleased to continue with the clinical radiology series, which I am happy very much and very much honored to combine the previous session and this session together with the Sudanese Surgical Club. And I'm so honored that Professor Rashid Ahmed Abdullah of the University of Khartoum has kindly gave his blessing to these sessions. Today, we'll carry on with the same topic with a special emphasis on the life-threatening type of abdominal pain. And the issue is very important. These cases usually go to the emergency departments, but with the different closure of emergency departments in Khartoum and in our country due to various medical and political crises, every clinician is now met with an emergency, whether in his own private clinic, in a small health center, or even in social gatherings. You'll find somebody who will call you all of a sudden that the neighbor is feeling sick. So I would like all of us to be prepared to diagnose these cases at a very early stage. Actually, ladies and gentlemen, these days our hearts are primarily with our young children, those who are the hope for a better future. They are the hope for a change in this situation in this country. And they've been struggling to learn. They've been struggling to learn and to find their place on the world map, forcing themselves into difficult situations. Girls hiding, and some girls out in the sun, in the burning sun, barefooted on the floor. And the others now doing the exams. Let us all pray for their success despite these difficult circumstances. So the country, instead of preparing good for these, it's preparing a very nice place for the suspected people trial. This is a place for the big, and that's a place for the young people. I hope this situation changes. Now, as we said last time, acute abdominal pain is a common presentation at the emergency departments. And as I have mentioned earlier on, it's a common presentation everywhere. You will see it everywhere now. The causes vary from self-limiting, simple things, you just reassure the patient or give him medical treatment, to life-threatening. Life-threatening may be medical life-threatening conditions or surgical life-threatening conditions. We will go through these. The modern ERs, as we all know, they have only 4 hours to decide on patient's management. That's why radiology is important to help them. Now, the ER physician is under pressure. It's between the thinking time and the action time. And we said before, last week we concluded that imaging helps the surgeon to decide whether to operate, when to operate, and when not to operate. So we'll go through the important aspects, which are the life-threatening conditions. You know, these are the 8 common conditions that everybody knows: gallstones, cholecystitis, appendicitis, etc. But the life-threatening ones are the important topics that we should discuss. And I always emphasize the red flags on this, particularly on CT. Of course, CT now is the answer for many of these situations. So these red flags refers to the hypotension complex, which shows collapse of the IVC. Remember, the IVC is usually larger than the aorta. When it's collapsed like this, it means that the patient is in hypovolemic shock, which is the emergency situation. And on the adrenals, adrenal enhancement should not be more than the liver and the surrounding organs. You find this more than the spleen, more than the liver. That needs shock situation, emergency situation. These are the common causes that are encountered for life-threatening conditions: aneurysms, bowel ischemia, gangrene, perforated ulcers, perforated diverticula, and there are some other rare causes like the eosinophilic peritonitis, which is a medical. It's a medical emergency. Actually, I should be treated urgently before it becomes a surgical emergency. And of course, this is rare, but if you work in Ibn Sina or you work in Soba Hospital, these are referral hospitals, and you will get all the rare things. So you have to be prepared for that. The other interesting rare thing which can happen sometimes is the vernix caseosa, which is the peritonitis that occur after cesarean section. If you know the thick covering, white covering on the babies, if that leaks into the peritoneum, it can cause them peritonitis. So obstetricians should be aware of this as a complication of cesarean section. Particularly our young colleagues who do cesarean section in the middle of the night, they might, find it difficult, and they find difficult cases and difficult circumstances, and some leakage of the amniotic fluid may go into the peritoneum and cause this phenomenon. Okay, so we go on to find the role of imaging in these situations. Imaging should help this ER physician or any physician to decide whether he's dealing with a life-threatening condition. Is it one of the common emergencies that we know how to deal with them, that we have time to deal with them, or is this a non-surgical condition? Example of non-surgical condition is that somebody comes with abdominal pain, and you may do the ultrasound and find the gallbladder is thick-walled, and in that case, somebody is raising hands. Okay. Please mute your. Okay. Now excuse me. I'll just seek some help. So it is it's an important thing to remember that angina. Yes, somebody raising hand, and there are some images of people on my screen. Can you deal with that, please? Thank you. Thanks, Ali. He's helping me from overseas. We're thousands of miles apart. Bless him. Now, the acute anginal pain, acute myocardial infarction might present with abdominal pain, might present with vomiting. And this is sometimes missed by frontline staff in general surgical departments. All their mind is in peptic ulcer, cholecystitis. And that's why we have to mention this. This needs urgent attention. Some noise as well. There are conditions which we're getting some noise as well, Dr. Ali. Can you hear that? Okay. Can you, and also, can you take the images away? Some people, images are blocking the screen. Even you can take my image away. Right? Now we go back to our topic. There are conditions where you can be careful. You can see them as frightening on the X-ray, but these are non-surgical conditions. The most famous is Hirschsprung disease in children. You can get big megacolon. The other condition also is the elderly with fecal loading, colonic obstruction, pseudo-obstruction actually, due to big retained feces. This one, the Ogilvie syndrome, these are non-surgical conditions. They may look like it's going to burst, but this loaded colon can be treated by just digital manual evacuation. The Hirschsprung disease is very important. We mention it because nobody should do barium studies. If you push barium here, it will not come out. It will not come out and it will cause obstruction. Okay? Now, the previous lecture, we went through the location of different abdominal pain that will guide us to where the problem and what to image and which tool to use. To use ultrasound for right upper quadrant pain, for example, to use CT, KUB for the right loin pains, for renal problems. And this, of course, we've been through this. I don't want to go through it again. I just want to emphasize on the life-threatening conditions, okay? And they can give all types of pain, either visceral pain, somatic pain, or referred pain. Now, the list is for the common markers, particularly for our young colleagues who are just building their experience. And we try to help them here. First thing is to be very careful with patient who is delirious or unconscious. He will not tell you that he has pain. The delirious one will tell you he has pain. If you ask him where is the pain, he will not answer. Okay? But the relatives will tell you that this situation has started with severe pain. So these type of patients, we have to be very careful with them. And we have to investigate them very carefully. This is number one. And they might have life-threatening conditions inside. The other type of pain is a severe back pain in patients who cry but can walk, and you ask them, raise your leg, they raise their leg. This is not disc disease. This is commonly due to pancreatitis, acute pancreatitis. So one has to be careful about that. Don't say give them sedation and wait till you send them to the orthopedic surgeon next day. No, look, exclude pancreatitis. And we can go through some tips about pancreatitis. The other severe abdominal pain where you cannot locate the site, obviously because of guarding rigidity. And you look here, you can't find, is this in the appendix, in the gallbladder, right lower quadrant, left lower quadrant, whatever you go through the whole list, you can't locate that pain. This is usually due to peritonitis, which means that the situation has deteriorated far. The other severe pain, actually, which we should all pay attention to, is the pulse, the simple thing, the pulse. The rapid, thin pulse. It always indicates internal fluid loss. Internal hemorrhage is the most important. And even, with obstruction, you lose fluids inside the intestine. And that's what explains the thready pulse in the obstructed patients. So patients with thready pulse and those with abdominal pain who's got either gas-full abdomen or gasless abdomen or abnormal gas position. 3 descriptions of the gas. You have to get them from your first X-ray. Is it gasful? A lot of free gas there? Or is it gasless? Or gas in an abnormal place? It should not be there. There should be no gas in the biliary tree, for example. Okay? No gas in the urinary bladder, unless you have done a catheter. No gas in the ureters. Okay? And then severe abdominal pain with signs of septic shock, the signs on X-ray, CT I mentioned. Now I remind you the blood pressure. But the blood pressure, yes, you will check the blood pressure and the lactase. The lactase is a good marker. It's a good marker in this situation. Maybe you don't have the lactase. You just rely on the pulse. Okay, أخوانا في الأقاليم وفي المناطق المهمشة. You can rely in the marginated areas, rely on your blood pressure measurement and on the strength and rate of the pulse. This septic shock again needs intravenous, because at that time patients will not complain. He will not tell you what's this and what's that. He's fighting for his life. Finally, severe abdominal pain with a mass. This can be a twisted ovarian cyst. This is one of the most painful conditions. If you see a young lady with a twisted ovarian cyst, hemorrhagic cyst, or dermoid cyst, it should be on the floor, rolling on the floor. She's not hysterical. This is genuine situations, and which might lead to gangrene. Therefore, you have to pay attention to that carefully. So I repeat, sorry for the repetition, but I gather we have a lot of the lovely members of this club who are young in their first or second year or third year. We have some medical students. So please allow me to repeat this again. Life-threatening pain, be careful with the unconscious or the delirious patients. Severe back pain, when the patient can move his limbs. Straight leg lazing for this does not show positive signs. Severe abdominal pain, where you cannot locate the site because of rigidity. This means peritonitis. Severe pain with thin pulse means internal hemorrhage or internal loss of fluids. Severe pain with gasful abdomen, obstructed, or free air somewhere, or gasless abdomen. Even peritonitis causes a loss of gas in the bowel. Obstruction, it will fill with fluid. You will not see any gas. I will show you cases. And severe abdominal with signs of septic shock, of course. And try to use the lactase if you have the facility as well. And of course, if you're suspecting pancreatitis, you do the amylase as well, although it may be late. But usually patients, by the time they arrive to you in my country, they have tried Hilba, Waharjal, Walmihaya, all these things. They mostly come late with these conditions. And finally, if there is a mass and severe pain, this is either abscess or a twisted organ. Okay? Okay, so we carry on. So what will we do with the situation in the ER? I'm now recommending, and we discussed this with Professor Rashid last time, that we should perform the fast ultrasound in all trauma units in my country. Focused assessment with sonography in trauma. This is also useful, not only in trauma, it's also useful in abdominal pain. And this is very easy to learn. This is very easy to learn. And I encourage all our young colleagues to put their hands onto the ultrasound. Ultrasound is safe. It is safe to the staff. It is safe to the patient. It is safe for the learner. It is safe for the teacher. It is safe for the environment. So don't hesitate to use ultrasound. Of course, silly, don't drop it because it's an expensive item. And concentrate, okay, on the rules of three. I give the rules of three. First, just look for fluid or blood, which will be thicker fluid, okay, and for collections, which mean abscesses. These usually in a very ill patients will be all very obvious, okay? And remember the source may be the peritoneum, Okay, peritonitis, perforations, hemorrhages, etc. And please look at the pericardium, because sometimes you can get pericardial effusion, which may cause cardiac tamponade, and you lose your patient. This you can just quickly put the probe over the heart, and you can see it's very nice view to look at the heart beating by ultrasound. Okay, particularly if somebody is learning new, he will see, oh, yes, I can see the heart. And look at the pelvis. Ectopic pregnancy is a life-threatening condition. And twisted ovarian cysts are life-threatening conditions. And here we are. This is free fluid around the liver. Okay, between the liver and the kidney. This is the Morrison's pouch on the right side, anatomically. This is the pericardium. This is a nice view of the heart. And here we are. This is the pelvis. This is free fluid in the pelvis. This is a uterus, bladder, and this is free fluid. When you see free fluid in the pelvis, it can be physiologic, of course. But those with physiologic, they don't come to the ER. So you think about local cause or general cause from the upper abdomen tracking down. And the most important is to exclude ectopic pregnancy. Most patients who come with ectopic pregnancy may not tell you that they are pregnant. Usually they are young. They don't have experience with maternity issues and the like. So it is important. It is important to understand the importance of fluid, free fluid in the abdomen. Okay. Now, what we propose now for my country, and I hope those of you who are friends of the minister or friends of the prime minister or friends of the other people who control my country, is to recommend to them these new models of ultrasound, these small portable ultrasound units. This is cordless. You don't plug it into any connection. You use your own mobile and you use the ultrasound device, and it can give you very quick information. This is very cheap. That's why it's not promoted by the big countries. The big companies don't like it because they don't make much profit from this. But we need this. We need this. We need this, and it should be generalized into the clinics in my country. And this is affordable. This is not expensive. And also people can ask, you know, the donations that come from other countries, if you ask them to give this, they will do that much quicker than giving you the money. Wastaghfirullah. Okay, we go to a gasful abdomen. Gasful abdomen is a serious situation, whether it is due to, this is due to.
It doesn't look like you have an app.
This is either due to free air or obstruction. Both situations, we don't want to see the abdomen like a football full of air. Neither intraluminal in the bowel nor extraluminal in the peritoneum. And of course, we said before that it's easy to see air under the diaphragm on a chest X-ray. But now we are talking about the massive life-threatening condition. We've just discussed last time the differentiation between the life-threatening cecal volvulus, which needs surgery, and the simple management of the sigmoid volvulus of the elderly by just putting a soft catheter inside the twisted area, through the twisted area, and you deflate the situation. So this is life-threatening. This is not life-threatening. No need for surgery on this one. There is urgent surgery. We have to seek the help of our expert surgeons on that. Okay, now gasless versus gasful. This is gasless abdomen due to gastroenteritis, which is a medical condition. But this is gasless, mainly obstruction, mainly filled with fluid, intestinal fluid, due to a carcinoma very tight apple core carcinoma, obstructing the proximal transverse near the hepatic flexure. This again will look gasless like that. Both situations, because that gastroenteritis is a medical emergency, but not a surgical emergency. Now, gas in abnormal places with this ugly gas in the gallbladder, gangrenous gallbladder. This is a real threat to life. Okay, already it's ruptured. There is air, there is fluid in the gyrotis fascia, in the retroperitoneum, and intraperitoneal fluid smearing. So that's life-threatening severe infection. And we mentioned the only exception for gasful abdomen if you have laparotomy, laparoscopy, or peritoneal dialysis. But obviously, the history is obvious. This will not come with acute abdominal pain to the emergency room. Okay, well, I showed this example before. I will show it again. Abnormal gas in an abnormal place. We should not see air in the wall of the stomach. We should not see air in the wall of the large bowel. It should be inside the lumen, here, inside the lumen. Even the amount of air should not be that much. This is too much air in the small bowel, in the jejunum, but that's a toxic alias secondary to emphysematous gastritis. It starts as a medical emergency, but if you need intensive support to the patient, if you don't do that, you will end up doing emergency gastrectomy, which is very serious surgery. Okay, the commonest life-threatening condition that every one of us will see is a perforated peptic ulcer, whether it's gastric or whether it's duodenum. The secretions which are inside the lumen are very irritant if they go outside to the peritoneum. And peritoneum is a very delicate structure, very delicate structure. Those of you who ever have the chance to help during Eid al-Adha and see the peritoneal and the mesentery is a very delicate structure with a potential space. It should not be, filled with fluid. It's potential most of the time. So if there is an ulcer, of course, this is an exaggerated appearance, okay? If there is an ulcer, it will leak to the lesser sac, and it can cause severe peritonitis. Leakage can also go into the retroperitoneal area, and all sorts of complications can occur. So, and this is an example where the contrast, this was given contrast, it has leaked from the duodenum into the paraduodenal spaces under the liver in the subhepatic spaces, okay? And even traversing the gastrohepatic ligament here. Right, so remember perforated peptic ulcer is the commonest encounter in your daily ER jobs, okay, for massive pneumoperitoneum. Remember to ask the patients about the steroid treatment. A lot of asthmatic people are on long-term steroids. Patients on rheumatology treatment are on long-term steroids, okay? So these are likely to have perforations. Now, value of X-ray here again is to reassure that there is no need for life-threatening conditions, like just following catheters and tubes. This is a VP shunt, and X-ray has shown it has broken, discontinuous, which is very important for, otherwise the hydrocephalus will get worse. So you could do the X-ray and you can assess this. Simple thing, simple examination, cheap, very quick answer. I have shown this before, retained foreign bodies, whether it's shash or it's an instrument or whether it's a coin, can be easily shown by X-ray, no need for CT or other tests. And this is an example of severe example of fecal impaction. Actually, this needs very rapid manual evacuation in people who are bedridden or hemiplegic and the like. Okay, now these are not life-threatening conditions at the moment, okay? But these are one of the 8 common conditions which you need to treat before they go and become complicated and turn into life-threatening conditions, which are the stones, particular CBD stones, right? Giving biliary colics, severe biliary colics. It's severe, but it can be intermittent, of course. And retained stones after surgery. These are the nuisances. Okay. The other thing which I did not include here is the bilomas, the leakage, the biliary leakage after biliary surgery or biliary interventions. We go further. Last time we mentioned the peculiar syndromes, the Merisi syndrome. Okay, and I gave the explanation, and that's important. If you don't diagnose it, condition will get worse and patient will suffer so much. The other is the gallstone ileus. Again, we explained this last time. And again, it goes, the stone keeps growing, it keeps enlarging as it passes in the small bowel from the food deposits and from the hemorrhage it causes. And then it gets impacted at the terminal ileum. Very interesting thing. These should be, we should be following them very carefully. We should get the surgeons to treat these conditions early. Now, the other warning signs that you can get is the presence of gas in abnormal places. There should be no gas in the biliary tree, particularly in the young. In the elderly, you can have an incompetent sphincter of Oddi, and then they can release air into the biliary tree. But in the young, that's very serious. This is either fistula, this is ascending cholangitis, which is a very grave complication. Okay? And the other thing which we don't like to see is air in the portal systems. The difference between the two is that air in the biliary tree remains central, does not reach the periphery, whereas air in the portal vein branches travels fast with a fast blood and is lodged peripherally into the margin of the liver. Again, this is a warning of pyemia, portal pyemia, commonly from appendicular abscess or appendicular mass or infected appendix. Because these drain, as you know, from the superior mesenteric vein into the venous confluence with the splenic vein to form the portal vein and then supplies the liver with 70 to 80% of blood supply from the liver comes from the portal circulation. The rest comes from the hepatic artery. Now, what about renal problems? Yes, we can have a renal problem which is life-threatening. And these are not many cases, usually infections, okay? Or calculus anuria, of course. If you have bilateral acute obstructions, which is rare, can also be life-threatening. And the radiology will have to diagnose that, okay? And you see ureters impacted in both stones impacted in both ureters, lower ureters, causing acute anuria. That should be obvious on CT scan or X-rays. So what is this? This is a staghorn calculus. Okay, staghorn calculus impacted in the renal pelvis with a lot of granulation tissue, and patient is septic. Look at this X-ray without contrast, no contrast. This is the low-dose CT, which we'll talk about later on. And this is causing sepsis and very serious. This condition will require, at this stage, it will require nephrectomy because patients will be septic, it will go into septic shock and all the complications. So this is one renal condition that can cause life-threatening complications. Everybody knows now about appendicitis, appendicular mass, okay, appendiculith, okay, and this is usually a good clinician can diagnose appendicitis by clinical examination. But we have seen many times that cases are difficult to diagnose. And the most important diagnosis which is missed is the early perforation of the appendix. This you cannot detect by palpation or inspection. Okay, you cannot detect by X-rays. This has to come by CT. Even ultrasound cannot show you this bubble of air outside. Yes, because all the place will have gas in the cooler. So we have to be very careful about perforated appendix. Perforated appendix is one of the life-threatening acute abdominal pains. I make no apologies for showing you CT and ultrasound of acute appendicitis, because if you don't diagnose them early, then they go into life-threatening conditions. Acute appendicitis, smearing of the peritoneal fat around the appendix, distension more than 6 millimeters of the appendix, fluid filled. Here we are, ultrasound, okay? Ultrasound showing you distended appendix, large, more than 6 millimeters, okay? Here, Doppler showing you hypervascular wall, acute inflammation. Here we are, finger-like structure on ultrasound. You should diagnose ultrasound. By ultrasound, you should diagnose most of the cases of acute appendicitis. More of the appendix. Here we are, non-complicated appendicitis. Look at the tip. Here we are, appendicitis with a smearing of the surrounding fat. Here we are, normal appendix, okay? Again, appendiculis, inflamed appendix, appendiculis in an appendix. And the most important diagnosis by CT is to tell you that it's retrocecal. So you don't struggle to find the appendix in the McBurney's points on anteriorly or on the other side. So it's retrocecal inflamed appendix. If you leave it, it will get complicated. It will go into life-threatening conditions. The other condition which I mentioned last time was appendicitis with pregnancy. Appendicitis with pregnancy. And here we are, here we need the help of ultrasound or MRI. Of course, MRI is very good in this. It can easily show you the appendix, whether it's complicated or non-complicated, and it can show you the fetus as well. Okay, this is the normal appendix here, right? So we finished with the right lower quadrant and appendicitis. We go to the left lower quadrant where we have diverticulitis. And as Professor Rashid mentioned, that this disease is now becoming common in the country because of eating sandwiches and stopping eating mulukhia and wake up. So diverticulosis, okay, and diverticulitis, inflamed thick walled, okay, with the smearing of the peritoneum around it, severe diverticulitis with the smearing of the peritoneum and obstruction of the colon, and the serious is the diverpericolic abscess, complication of severe diverticulitis, rupture, and may even go to give us complete peritonitis. So it's very important to detect this at the early stage of inflammation. And maybe you will need, surgeon may need to do diversion surgery for some time, colonoscopy, colostomy, all right? So don't wait for the diverticular disease to become an abscess or to perforate to give you peritonitis, which will become life-threatening. Again, I show these cases repeatedly again and again to stress the points. This is gasful abdomen, distended colon on X-ray. Barium enema have shown that this is upper core region. Of course, if you have done CT, you will see this tumor very clearly, and you can do the staging for the tumor management. So again, here we are, upper core carcinoma, causing severe obstruction, gasful abdomen. Gasful abdomen is a life-threatening situation because this, if you leave it, it will perforate. The other serious condition with central abdominal pain where you cannot locate it to the appendix. It's not in the gallbladder, it's not in the left colon or sigmoid colon, etc. This is central abdominal pain, where the bowel becomes very edematous, very edematous. On cross-section, it becomes target-like, differential enhancement of the mucosa, different from the submucosa and musculosa. Okay, this is acute bowel ischemia, which needs contrast-enhanced CT. We'll mention this later on. And that's a very serious condition. If you leave it, it will cause gangrene. And that's a very serious complication. We mentioned the back pain. In patients who comes with back pain, severe back pain, he's a man, he's crying, or a woman is crying, and you think this is a disc. You do the straight leg raising, no problem. He can do that. Okay, so think of acute pancreatitis. Do the amylase level. Okay, acute pancreatitis goes into different stages. You can study them. Early is swelling, little fluid. More becomes hypodense with a lot of free fluid in the abdomen. Then it becomes necrotic and forms phlegmon, thick material around and tracking into the gyrotous fascia and the lateral corneal space. And later on, it will form pseudocysts, which may get infected. So pancreatitis, the main problem with pancreatitis, remember, is not its local complication. Although they are serious, it can erode the blood vessels. Or the problem is this pancreatic froth or pancreatic juice. If it goes into circulation, it goes into the circulation from the peritoneum. When it leaks into the peritoneum like this, okay, it gets absorbed by the veins. It goes into circulation. It's toxic to the heart. It's toxic to the kidneys. It's toxic to the lungs. So you get multi-system failure. Patients would need ICU, and you will pray for them to recover from that. So before this keeps leaking, you have to treat the patient. And sometimes people have to give the patient suppressants of pancreatic juice excretion, the octreotide type of medicines. So make sure that pancreatitis is diagnosed early, right? And treated early. Okay, gasless, gasful abdomen. Gasless when the intestine is full with fluid. Commonest problem for obstruction is adhesions, particularly in females, because of the repeated cesarean section, cholecystitis, and maybe appendicitis as well. And this is the tight, this is the transitional zone, the narrowed segment. Okay? And this is what I mentioned last time, is the feces sign. Feces appearance in the, usually feces are in the large bowel. But if you see feces in the smaller bowel, you know this is definite obstruction. Definite obstruction. Small bowel feces sign. We mentioned last time, of course, and everybody knows that aortic aneurysms are a threat to life. And these patients, they are rare still in my country, but they kind of care. Okay? And inshallah, when the country opens for foreign investments, you will get businessmen from all parts of the world. Let us dream. Now, ultrasound is useful to monitor the progress of aortic aneurysms. You keep measuring by ultrasound, simple measurement. You don't need CT in the initial follow-up phase. And you allow up to 5.5 centimeters size. If it reaches 5.6, you refer the patient to the vascular surgeon. Here we are aneurysm. This is silent, but this one is started leaking, actually ruptured, big hematoma, who active leaving while during the CT scan. Contrast is leaking outside. Very dangerous. This type of patients, we don't want them in our department. We rush them straight to the theater area, and we call his vascular surgeon to meet their patient over there. Okay? So this is a life-threatening emergency. Of course, these patients will come pulseless or with thin, rapid pulse. Okay? And it will come with central abdominal pain. Central abdominal pain. And now the modern treatment of these aneurysms is by interventional radiologists. And I hope our young colleagues there who are taking this trouble, you give them enough support and give them cases at an early stage so they can help you by inserting stents, pantalon-like stents into the EVAR repair procedure. Okay, just to mention, obstruction by non-malignant situations in children, rare in adults due to intussusception. Okay, this can be gasless as well. Look at this, no gas here on this side of the abdomen. And that's intussusception in the adults due to polyp in the large bowel, usually due to lymphoma. Okay, now more about the colon. Ulcerative colitis and other types of colitis, they may be complicated with acute toxic dilatation. Acute toxic dilatation, which you have to diagnose early and start medical treatment early. Because you know, for ulcerative colitis, if you have to operate, you will have to do the total colectomy. Okay, it's good, curative, but try to avoid that if the patient can manage, and should be done on non-emergency situations just to avoid malignancies. This is ulcerative colitis, typical tram or pipe stem appearance of the colon. Here, colon is featureless. This one is interesting because here, this is a pregnant lady. This is the head of the fetus, this is a spine, and she developed acute toxic megacolon. And you can see these mucosal islands. This is due to ulcerative colitis, complicated ulcerative colitis. So ladies with ulcerative colitis, if they become pregnant, should be closely monitored. Okay? The other medical emergency, which can look like causing thumbprinting, just like ischemia, is the pseudomembranous colitis. Okay, pseudomembranous colitis. You find very angry large bowel, usually obvious on the transverse, which makes it easier to diagnose. Okay, and you see this edematous wall, edematous with thumbprinting. That's due to Clostridium difficile. You need to give the proper treatment for that and to stop other antibiotics which have predisposed to flourishment of the Clostridium. And that's a medical emergency. You have to treat before they perforate. And then it becomes a very terrible surgery to do. Okay. More fun again with the shashoma. Okay. Of course, they call it in the Western gossypioma. People talk about how he missed it. So that can come with a mass. With a mass. The shash is left inside, and then it keeps attracting peritoneal reaction around it. The trouble is it may get infected. And that's very serious. Infection in presence of a foreign body is a disaster. Even if it's like an orthopedic device or it's a T-tube or whatever tube in any foreign body, even the central line in ICU. When patients get infected, the central line becomes a problem itself. Okay, and people have to change them frequently, have to change the central line, for example. So foreign body like this should be removed, should be removed. Now, the serious thing is the hernias. I said last time, they can be missed. They are very difficult to diagnose clinically and very difficult to diagnose radiologically, unless you do good CT. Look for the swirling sign, look for the discrepancy in the enhancement pattern and the distension pattern. This is fluid, like abrupt cutoff. This is abrupt cutoff between the normal and the abnormal. And sometimes this is trapped inside internal hernia. You get one loop dilated, massively dilated. If you leave it, it will strangulate and becomes gangrenous. Okay. Now, internal hernias, this is a very difficult topic. I recommend that people who are doing surgery should read about it. I don't bother everybody with that. But this shows when it's neglected, what happens? It becomes gangrenous, small bowel. Okay? And there are so many. It can be broad ligament in the falciform ligament hernia, even in the obturator hernias in the pelvis as well, paraduodenal, etc. One other medical emergency that we mentioned the pseudomembranous colitis. This is typhlitis, which I mentioned before, and I repeat again, typhlitis. This is a patient with leukemia who's developed the situation. They become very neutropenic, characteristic. They are neutropenic, and nobody should try to do surgery on this. Very, very, very troublesome. Don't think this is an appendicular abscess. Okay, this is typhlitis, which is a rare type of colitis affecting the cecum and ascending colon. And it's a medical emergency, not a surgical emergency. Now, go back to أهلنا في الجزيرة, the malaria spleen and the bilharzia spleen, right? And huge spleens can rupture spontaneously. They can develop splenic abscess, and that can rupture, okay? And with minor trauma, they can rupture. Even the child, granddad or grandmother carrying a child, and the child kicks the mother's or grandmother's tummy, he can cause perforation or a rupture of the huge fragile spleen, leukemic or due to the other so many causes of splenomegaly, tropical splenomegaly in particular. The other rupture, which can be life-threatening, is the ruptured tumor, particularly ruptured hepatocellular carcinoma if it is in the subcapsular location, like this one. It has ruptured. Okay, I've showed this before. Look at the density of the fluid here. Very dense. This is blood. Okay, CT is very good in picking fresh blood. It's always dense. Okay, even when it is diluted in the peritoneum. So ruptured tumors, ruptured abscesses, ruptured fragile spleen. Another situation, again, when ischemia is there for a long time, you start to get featureless bowel, edematous, and you lose all the hosterations. You remember the hosterations? We lose them because the wall is edematous. The wall is edematous. And you may see there is a filling defect in the wall, like mural hematoma in the wall of the stomach. Okay, look at this, featureless, no folds at all. Valvuloconjunctivitis, we have thousands of them in the small bowel. You don't see any folds here at all. Okay, make a flat, and that's chronic ischemia, which then it can become worse. Then it will become acute, but you will find that this is already existing. The other example I showed before is the phenomena of aneurysmal dilatation of the bowel in cases of lymphoma. This is not aneurysm, this is aneurysmal due to lymphoma. As you can see evidence here by the PET-CT. So these patients may need diversion for some time, but of course these are now curable by chemotherapy. Very good response to chemotherapy. Yes, back again to unusual presentations of the appendix. Okay, this is a young man presenting with pelvic, young girl presenting with pelvic mass and severe pain. This is not ovarian cyst. This was actually an appendiculus and appendicular abscess. Remember, the appendix, in 30% of cases, it will be pelvic. I don't know why. All the papers now we read is that its appendix is more common retrocecal. Whereas when I was a young man, then we used to know that these are rare. Right. Another type of twisted structure, mass twisted structure, patient crying, shouting, is the teratodermoid cyst, which contains fat, hair, and teeth. Very interesting structure. Actually, this patient had it bilateral. And again, this will come with severe pain. If he twists, then that's it, severe pain. Right? It's very important to identify this so that you try to preserve the ovaries if possible. Okay? Now, going back to the hernias again, the external hernias, not the internal hernias. You have two types of external hernias in the abdominal wall. Of course, you have the inguinal, the femoral, the obturator, etc., etc. But these are the ones I'm showing them because their complications are different. If you look at the Richter's hernia, it's a small hernia. You only get the margin of the bowel. Only the margin of the bowel is herniating. But that margin contains the blood supply. So you cut off the blood supply, as if you have applied a surgical clamp. You cut the blood supply, you will get local gangrene here and strangulation of the hernia. Where is the Spigelian hernia? This follows the rules of anatomy. This is Spigelian hernia. It goes along the arcuate line here, okay, at the margin of the rectus sheath, lateral margin of the rectus sheath. And it bulges easily because this is the weak area of the Spigelian ligament. And it can enlarge and then obstruct. And sometimes, or on a lot of occasions, it's intermittent. Patients get the pain, he comes to the surgeon, and the pain is free. Then they think this is malingerer. But if you look carefully or examine carefully, you might see the hernia or feel it. You may not be easily felt because it is soft. It's soft. But on CT, on ultrasound, we can diagnose that for you and explain the cause of obscure pain. Mass and fever is very important to remember, particularly in the coming period. Hope not. You may get a lot of infections. And our great expert will be talking to us about this next week, and Dr. Fatih. This is an abscess in the liver. The patient will become toxic, and in rare situations now, you can get Brucella abscess in the liver, in the abdomen, the spine. Of course, Brucella prefers the spine. Okay, and we have to remember this. So you need drainage and you need medical treatment, and you assess the history. This will be febrile. The other febrile patient is the amoebic liver abscess, and that's again, hopefully, will not increase during the floods. And that's important to diagnose and to drain. Some people say just give them metronidazole. But I remember when I was in SOBA, we used to drain them. Why? And our argument with that when the deranged liver cells, these are destroyed liver cells by the amoeba. These destroyed cells cause a humoral factor. They cause, they become irritant to the body. So patients with amoebic liver abscess, they become very toxic, dirty, earthy looking. And they look very ill, very toxic. And we found when we drain them under ultrasound guidance, they very rapidly improve because the irritant material, not the bacteria, because we don't see the amoeba. Amoeba is usually hiding in the wall here. When we don't remove the amoeba, of course, but when we remove the toxic, the deranged cells, the patients improve greatly. And I had a collection of these in SOBA before. Of course, it can be seen by ultrasound and by CT as well. So this, if it ruptures, why am I saying this is life-threatening? If it ruptures into the peritoneum, then we have serious life-threatening conditions. So we're talking about prevention of life-threatening conditions as well as diagnosing life-threatening conditions. Again, severe, I keep jumping from one case to the other so that you do not get bored. And I show you here a very severe example of mesenteric occlusion, where not only mesenteric, even renal artery occlusions. Here we are. The celiac is blocked, okay? The superior mesenteric is blocked. The left renal is blocked, okay? Mind you, this situation may occur with cases of COVID-19. But anyway, this case was not there. This is a patient with a severe vasculopathy with thrombosis in multiple blood vessels. And he developed, look at this bowel. This bowel is featureless. Even you cannot see the margins of the bowel. No enhancement. This part is enhancing, this is healthy. But this is healthy, enhancing. But here, this wall, you can't see the wall because it's already ischemic, severe ischemia. Okay? And here we are. We show you the CT of the aorta, the inferior vena cava, and the superior mesenteric artery sticking up. And you can see there is atheromatous narrowing of this artery, predisposing to the chronic ischemia, and then he gets a new clot, and then it goes into acute on top of chronic ischemia. And this is the normal superior mesenteric artery. Normal superior mesenteric artery, good enhancement. Here we are. We go to gas. We said gasless abdomen, gasful abdomen, and then gas in abnormal places, which is gas in the free air in the peritoneum. There should be no air between the liver and the anterior abdominal wall. This is perforated duodenal ulcer, and that's very small spot of air outside the stomach. We're not allowed to have any air outside the stomach, the colon, and the small intestine. And this is a time to pick these cases, very rewarding when we make such a diagnosis as radiologists. We pick that early, we pick this early, okay? We don't wait for a gas-full stomach. We diagnose it as a stage of gas in abnormal places. Here we are, gas-full abdomen, distended stomach, and a lot of air around the stomach. When you see both sides of the bowel wall as if it's drawn by a pencil like this, you know there is pneumoperitoneum, perforation, severe perforation. Here we are, another medical emergency, but this is in children. Necrotizing enterocolitis. No surgery, don't touch it. This needs very aggressive medical treatment, and hopefully it will settle. Just like the pseudomembranous colitis we showed you before, just like the typhlitis we mentioned before. Here we are, more of the ischemia. Ischemia is very important to diagnose. Thumbprinting, this sandwich-like appearance, different layers, thick, small bowel, And here we are, abnormal differential layers of enhancement in the small bowel because there is edema in between the two. And this one has gone into ascites now. This is late phase now. Poor enhancement. This is early, intense enhancement. Okay? Like shock. And here we are late, leaking, and poor enhancement. We don't want to see any cutoff of the blood supply to the bowel. Because bowel needs a lot of supply to digest the food for us and start the metabolism. Here we are, an abscess. So it's abscess. Okay, rare, commonly pyogenic, but you see in my country, it's commonly tuberculous. Okay, and this is the subphrenic abscess, usually on the 10th day post-operative surgeries. Hope not. Pancreatitis, those who are interested can read about it. I give the reference here. And you can go to the Belzahar classification, the revised Atlanta classification, the original Atlanta classification, etc., etc. And here we are, these are the different types of pancreatitis. Perforated gallbladder is a serious complication again, right? Now, we have learned from last time that when to use ultrasound, when to use chest X-ray, and when to use contrast CT, okay? And when to use low-dose CT, CT-KUB, without contrast. CT-KUB, I would like to recommend it to my country. Those who have CT, please, please try to use CT without contrast. CT without contrast and low dose. It will be a quarter of the dose, radiation dose to the patient, particularly if it's a child or a lady, young lady. It will be a quarter of the cost to the patient. And you know, our people cannot afford these expensive tests. A quarter of the test. It will be a quarter of the time to be done. CT with oral contrast عشان يمشي لغاية ما يوصل إلى الكولن وإلى آخر. It takes nearly an hour to do so. You cut that time into 10 minutes. Into 10 minutes, 5 to 10 minutes if it's a young patient. Albert just taking off his clothes and putting them, he goes into the screen and then it's only 3 minutes, the scan is done. So it's a quarter of the cost, a quarter of radiation dose, a quarter of the time. You need a quick answer, somebody with perforation. You need a quick answer, your surgeon wants to operate. The other thing, a quarter of the trouble. You know this, when you give patients fluids to drink, contrast media to drink, and you give him an injection and he might develop a reaction, all this trouble, you don't need that. You can do the CT, get a lot of emergency answers without. And also it's good for the owners of the machine, the private owners, the investors, because in that time, instead of doing one patient, he can do 4 patients. And then his waiting area will be clear very quickly in the same time, and he will get the same money for that. Actually, he will not use contrast. He will save more money. And he will not use high energy with the tube of the CT will live longer. So it's cost effective for all of us. It's very important for the surgeon because he will operate very quickly. It's unfair to keep doing X-rays, ultrasound, and CT, and then after 6 hours, send it to the patient, to the surgeon, and when he operates, it is already perforation and peritonitis. Okay, and you can keep this image with you all in the ERs and what have you. Now we've been looking at the investigation of acute abdomen, and we looked at the literature with my group here some time ago, a couple of years or a few years ago. And we found that the guidelines, which were written by big authorities, are so many things. Particularly, they have all the lab tests, they have all the CT, MRI, ultrasound, everything. And a busy ER physician cannot find time to go and follow all this to to know what to do for his patient. So we're trying to help our ER physicians and to help you as well. This is the European way of assessing acute abdominal pain. And this is the Japanese. Okay, now that's not easy at all. Japanese are more serious with dogmatic things and guidelines, okay? Even this is a primary care physician, let alone the ER physician. And this is getting so much complicated. And ER physician has got only 4 hours to decide on the management. And you in your peripheral clinic or عيادة في أهلنا في الحاج يوسف أو روير في الثورات وين في المناطق كده يجيك patient, you don't have all these facilities. You can only rely on a few things and you can order a few tests. So we want to look at this. With my co-authors, I salute them, we published some work on the imaging of non-traumatic acute abdominal pain in adults presenting to the emergency department. And we also give another publication questioning the use of plain X-rays. Should they persist or should they be replaced by alternative imaging for acute painful non-traumatic abdominal pain? Of course, here they have everything, CT, MRI, you name it, dual CT, everything. So we try to be careful when we take this. I'm grateful for my colleagues who have been very helpful with this work, okay, in the beautiful city of Riyadh. Now, when we did this study, we found that people were still, at that time, this was 5 years ago, people were still using plain abdominal radiographs. For most patients, we were surprised actually. We are in civil, you know, in a sophisticated hospital. Why is that? We thought everybody is having CT. And we found that people were using conventional CT. Very little have used low-dose CT. And ultrasound, again, was very little. We were surprised. Why did they use little ultrasound? It's simple, it's quick. I'll give you the explanation. MRI was done for one patient who was pregnant. The most important finding is that when people used X-rays and CT, both were used, there was poor diagnostic congruence of 35% in abdominal pain cases, meaning that the X-rays were not sensitive. CT was much more sensitive, okay? Moreover, we looked into the literature to see about this ultra-low dose CT. Is it with different techniques? Okay, those of you who are interested can read about this in the literature. Is it good? All the companies produce that, Siemens, Toshiba, GE, etc., Philips. So they use different techniques. And that, again, low dose radiations to the patient. As I mentioned, quarter of the dose and quarter of the. So we're now trying to propose a triple tier algorithm for you to use in acute abdominal pain. This should help you to make the appropriate imaging choice in the appropriate sequence, which is first and which is last, and within the limited time. Okay, if you accept this protocol, you can keep it a pocket guide in your mobile or you make a poster in the wall, if you accept it. And I suggest that our young men will do a study on this, study on the ER, and I can help with that, with the supervision of our great consultants at home. Have a look at those who have X-ray only, have a look at those who have X-ray and CT, and those who have, say, CT only. You will find them. In these, you know, these things are in the private hospitals, I know, but you can trace the information. We have trainees there. And then come with a conclusion. Don't take my conclusion straight away. And try to strike a balance between the accuracy of tests, the severity index of the disease, the availability of the equipment, the target for hours in the modern ERs, the radiation dose and the test sequences, okay, which is first. And I would like to suggest to you that it's a 3-tier system. For tier 1 cases, in places where you have CT, you only do X-rays for fecal impaction or ileus, or drainage catheters or foreign bodies, like the examples I show you. Everything else should go to ultrasound. If the patient is jaundiced, or it's a gynae problem, or it's a young patient. This is tier 1. Tier 2 is the patient with very severe pain, okay, or critical. If critical, stabilize first, and then do CT, enhanced CT, dual CT. If it's stable, do low-dose CT. It will give you stones, appendicitis, diverticular disease, infarcts, etc., etc., etc. Okay? If the patient seems obstructed, you do enhanced CT to find the cause of obstruction. Sometimes you get tier 3, which is complex masses. Something you cannot, somebody who's drowsy, you don't know what's happening. Maybe you need to observe, but don't send them home. Or pregnant patient with ultrasound negative scan and still severe pain, you do MRI to exclude acute inflammations. Or if somebody who has CT negative and still got severe pain, you do pan-endo or pan-endoscopy, colonoscopy and gastroscopy, both of them. With this, you can sort out very quickly any case of abdominal pain. That's if you have CT and if you have endoscopy. If you are like some of my people in the districts and in the marginated zones, they don't have CT. What can they do? What we'll do, we do a good X-ray. Make sure that your X-ray machine is good. Your X-ray specialist and technologist is good, and you make him happy. He will produce good X-rays. We used to use this when we were in the country before. We practiced before CT comes, but we had excellent technologists. Excellent technologists, I remember them. We see every bit of detail on the X-ray, chest X-ray and abdominal X-ray, the bones X-ray. The other thing is to add ultrasound and then combine the informations from the two. All threatening conditions, you can diagnose them by combination of X-ray and ultra. And I have shown you ultrasound of perforated gallbladder. I've shown you ultrasound of aneurysms. I've shown you X-rays of perforations. I've shown you X-rays of ileus. Even medical emergencies, we have shown you pseudomembranous colitis, typhlitis, everything you can see. And you need a good doctor who is kind to our people in the districts, who is compassionate and who is thoughtful and who is intelligent and who is committed to a good clinical practice. Ladies and gentlemen, it's always a pleasure to enjoy your company on the Friday evening. We will continue, inshallah, for the welfare of our trainees in the Sudan Medical Specialization Board and the young consultants. Okay, we look forward to the next meeting, which will be related to the flood complications in the country. And I welcome Dr. Fatih Zain, our expert in infectious disease. We will do the session together next week. Till then, I wish you all the best. وأوصيكم على عصافيرنا اللي بيمتحنوا في البلد وبيغنوا، وأوصيكم على التور الكبير اللي اسمه السودان الشايلنا هناك. السلام عليكم. Thank you very much.